Thank you, Emily, for being here with us today. Could you introduce yourself and could you tell us a little bit about your background?
Sure. Emily Perrinez. I have been working at the Academic Health Center where I'm employed for about 5 years now. When I started, I was in stroke program management, supporting both of the TJC certified comprehensive stroke centers that we run out of our academic medical center. And really got very involved in both the stroke population and the clinical workflows, and then also deeply mired in the data. We collect a ton of data for our stroke patients. It's it's a population that has a lot of direct support because of that certification, and we're really interested in how we can improve the quality of stroke patient care. In the hyperacute stroke patient, most of that is really about timeliness. Appropriate clinical diagnosis and timeliness of intervention. So the work that we were doing, in that space was really around timeliness, and that's how we got connected with Viz AI.
Yes.
About a year ago, I transitioned into a new role. I'm now the director for telehealth operations, so the portfolio that I'm supporting within the organization has broadened. But when I think about the value that our relationship with Viz has really brought into that space, the sort of overall space of telehealth, and the marriage of a really high quality technical workflow with an improved clinical workflow, I think it's just an exciting place to be. I'm really happy that even though I've transitioned out of stroke, I'm still able to support the work that our organization is doing in partnership with Viz.
Yeah, we thank you so much for that. So you've been using our Viz LVO technology, which is AI-powered LVO detection, the communication hub, and it aligned your acute stroke workflow pretty well. Can you talk a little bit about that?
Sure. When we first went ahead and got to know your team and moved forward with the implementation of Viz, we have a really high-powered clinical team, very interested in providing comprehensive care to our patients, and we saw that there was an opportunity to really improve the coordination of that care pathway for the hyperacute stroke patient. And in the ischemic stroke patient, we knew that we had timeliness of intervention, and we saw within our data that we had opportunities to really improve how we cared for patients. When we first implemented Viz, what we were able to achieve was that well-coordinated clinical care pathway married with real-time communication that allowed visibility and full transparency to the needs of the hyperacute stroke patient from the moment we had visibility to them, whether they were presenting at our doorstep through the emergency department or whether they were coming to us as a transfer case. And because of that, we were able to do really timely decision-making, clinical decision-making, engage our clinical teams, engage our intervention teams, and ultimately had great success in reducing time from arrival to intervention because of that.
Yeah, it's really nice. So transitioning into the inpatient world where we see a lot of those same barriers, a tough nut to crack, and you're one of the first of 10 national sites to pilot our new Viz Connect post-acute stroke technology, which is designed to improve those same barriers that we see in the hyperacute stroke phase, but now in the inpatient setting. Talk to us a little about the motivation and the barriers that you assessed before you decided to commit to pilot with us.
Yeah, so I think, we had, like you said, we really had great success in that hyperacute space. We knew that we were able to get patients the intervention they required. We were dispoing patients appropriately within the hospital setting. And then, as you mentioned, there's still a lagging opportunity in the post-acute admission. So the index stroke admission, but following those acute interventions, where patients, we sometimes clinically can be a bit at a loss of how to best manage the patient as we are approaching the time of discharge. And specifically for those patients where the etiology of the stroke is challenging and we really can't gather all the clinical data we need in that index admission to know how best to care for those patients, we have to go outside of our clinical stroke team and elicit the help of other specialists within the organization. So when we learned about the Viz Connect tool, as sort of an augmented platform for the Viz app and the Viz technology, we recognized that we could take a patient population that can be quite vulnerable close to the time of discharge, and really bring the resources that they're going to require right to them, right to their bedside.
That's
to
pretty
offer
amazing.
them intervention in that admission.
When we do, a national evaluation of the barriers on the cryptogenic stroke or ESIS patients where, the cause of stroke is unknown, patients are in a vulnerable state, and in order to prevent that second stroke or that next stroke, we must uncover why.
Exactly.
And so this tool was really designed with that in mind. And I think when we discussed your barriers and, potentially long length of stays, incomplete care, we kind of built the magic button to get your neuro or stroke providers to that heart team member, to that electrophysiologist or cardiologist. Talk to us about how you rolled it out. What was that like?
Yeah, so it's funny because when we think about what the cryptogenic pathway or the clinical workflow for those patients looks like, I would say that in some ways it wasn't well defined. And I think what we were especially missing in that space was this connection point to the other services that patients were really going to need in order to be treated as comprehensively as possible. So what we did was we had, our clinical teams, the neurologists, the interventionalists, and our radiology teams are just so enamored of the value of Viz. There was no question. We've never really had to sell the concept to people. And so we felt that we had an opportunity to broaden the value of that platform into these other disciplines, specifically for cardiology, and the cardiologists who can come and help intervene with the stroke patients prior to discharge. We really didn't struggle much in eliciting some support from cardiology. We leaned heavily into our APPs because they tend to have that real direct bedside understanding of patients, and they are doing so much of that discharge care coordination. So if a referral is going to be written for cardiology at discharge, the APP is probably the one who's going to have visibility to it. And so we basically asked our stroke APPs, how would you all feel if instead of putting the referral in and then doing a follow-up at the patient's post-discharge appointment 2 weeks from now, what would you think if we just gave you the opportunity to connect directly with the heart team? And they said,
right in the hospital, right then and there,
right in the palm of your hand.
I would say, data suggests that there are a large amount of stroke patients, cryptogenic or ESIS, that need a form of long-term cardiac monitoring, whether an external device or an implantable loop recorder. There's strong data in favor of catching these patients while they're in the hospital and getting them that security system that they need before they leave.
Yes.
And I would say, after our workflow conversations, the process pre-connect was pretty broken.
Yeah, really, there wasn't, I wouldn't even call it a workflow or a process. Basically, patients were ready to be discharged. We would put a consult or a referral in, and sort of like cross fingers that patients were ultimately going to get connected and get an appointment. And, there's all kinds of barriers. Once that patient leaves the hospital, there are many barriers to getting them the care they need. You're dealing with length of time. You don't really know what the patient is doing in the interim. Patients tend to lose the sense of urgency after they leave that index admission. They're so motivated to be treated and to be well when they're in the hospital, but as they go home and sort of settle in, they sometimes don't really understand what their needs really are. And unless they have really fulminant arrhythmia, it's likely that they're not even particularly symptomatic at that point. And so we may have lost an opportunity by bringing, really what I think we did was we took the burden of follow-up care off of the patient and we moved it into the clinical space, which is where it belongs. And then we made it incredibly easy for the clinical team to access the patient.
And it sounds like a very complicated workflow in itself, but how did the technology make this easy or doable for your team?
Yes, it's not complicated. In the end, this requires literally, it's not even a push of a button because we all are on our smartphones. Just pressing the refer icon in the app, which immediately sends a message right to our heart team. And once the heart team has the message, they then have full visibility to the patient and the care that the patient has already received up till now. Our stroke team can identify, we believe this is cryptogenic stroke. We're concerned for this. Please consider whatever device you think is most appropriate. And then our heart team has the ability to go see that patient prior to discharge, do their own clinical evaluation, make their own assessment. We are in continuous communication, so the stroke team and the heart team can be speaking the same language at the same time. We're not relying on an old after visit summary that now has lapsed for 2 weeks. And then we also catch the patient in that critical moment when they are very invested in their own care.
Yeah, it's interesting. When we did an analysis, a tech utilization analysis during your pilot, or during the pilot, still ongoing, of the cardiac response time, we evaluated it to be under a minute, even on the weekend, no less. So I think I would venture to say that has cardiology been receptive so far?
Cardiology has been incredibly receptive. It's so easy to participate in the care of the patient. The VizConnect tool has really removed those barriers to care. And because it's so easy to do that, your phone dings or buzzes, you look at it, you immediately can go and see exactly what's going on, make whatever recommendations you need. If the patient needs to be physically evaluated, you have the ability to do that right then and there. So again, as we expected, given the experience we had when we first implemented Viz within the stroke program, the tool really sold itself.
Yeah, we like to consider this, a workflow optimization tool, right?
Yes.
It's something that's taking what you first invested in, and it's making a bookend, an end-to-end for the patient journey, which is the goal.
Exactly, and I can speak from a telehealth perspective in general. So frequently, telehealth technologies fail at that point where the clinical workflow and the technical workflow need to be aligned. And what we see with this tool is that there's a perfect marriage between what the clinical workflows are, the need for timely, appropriate, direct patient care by multiple disciplines, and how the technical workflow is supporting that. So really, in that sense, it is a perfect marriage. And those marriages within the telehealth realm are the ones that create successful outcomes for patients.
Couldn't agree with you more. It all comes down to communication, right?
Yes.
Yes.
Definitely. And that the Connect tool makes that communication natural, fully visible. Everybody understands how to text, but now we don't worry about who's seeing these texts. Are these texts being utilized for the appropriate reasons? It's just so clear. Really, yeah.
And if I'm not mistaken, there's a research project. You're undergoing a research project around VizConnect tool and utilization.
We are, yeah. We're looking very closely, as we did with the original Viz tool when we really got into measuring timeliness and trying to understand if we sort of sliced and diced our stroke population, where could we see the greatest value? And we were able to identify not just minutes, but literal hours saved for some of our patients when it comes to neurointervention. We're looking at the same thing now. And what we've found is not only is the timeliness just so apparent, like you said, 1 minute to review, less than 1 day to see the patient and actually intervene, but we know that from a volume standpoint, we're actually seeing and treating patients that otherwise would have been lost, that we wouldn't have even gotten to.
So you would say you've seen an increase in referrals, you've seen a quick response, and how's the relationship with cardiology? Did you have a relationship with them before this? What was that like?
Large academic medical center, we've got providers and APPs and graduate medical education. I would say that from a collegial standpoint, our stroke providers and our cardiology providers would have said they had a good working relationship. But when it comes down to not something more than just amicability, but the actual ability to collaborate and
shared
approach
decision
patient
making
care in a really collaborative way, putting the patient at the center, taking into account the really valuable input from the different clinical teams, and then moving forward with the decision and implementing in real time, all before the patient is even discharged, that is a total game changer for us.
Yeah, from days to minutes, right? Yeah.